And we are back with George Michael. This is Med School Radio, and I'd just like to say, if you're interested in any of the content in this show, please visit the website. Okay, let's get to it. Hello everyone, this is Simon. I'm back again. Today we're going to be looking at medbullets.com, and we're going to be thinking about kidney embryology, and we're looking at some of the MCQs that they have on the website. So I'm just going to go to medbullets.com, and we're going to be reading first the overview, and then we'll look at the MCQs. So let's go ahead and read through the overview. So they have a nice photo here of the development of the kidney. So first we'll start with kidney development. So this progresses in a cranial to caudal direction, intermediate mesoderm to urogenital ridge, nephrogenic cord to urinary system. Then there's the pronephros. Non-functional, appears by week 4 and then degenerates by week 5. Then is the mesonephros, development induced by pronephric duct, forms mesonephric duct, Wolffian duct. Interim kidney for first trimester, and then opens to urogenital system and gives rise to the male genital system. Then comes the metanephros, develops from the mesonephric outgrowth called the ureteric bud during week 5. Fully canalized and functioning at week 10. Nephrogenesis continues through 32 through 36 weeks of gestation, and the derivatives include ureteric bud, which develops into the ureter, pelvises, calyces, and collecting ducts. Aberrant development may result in congenital malformations of the lower urinary tract. Then we have the metanephric mesenchyme. Interaction with the ureteric bud causes metanephric mesenchyme to differentiate the renal structures from collecting tubules to glomerulus. Abnormal interaction with ureteric bud may cause malformations. So this is a question that comes up on the test, the MCQ. Remember that the ureteric bud difficulties will cause the malformations. The ureteropelvic junction with the kidney, this canalizes last. It is the most common site of obstruction in the fetus and results in hydronephrosis. Thinking about the adult kidney, the embryo grows faster caudally, causing a change in location of the kidney from S1 to S2 to a final position of T12 to L3. And regarding the developmental abnormalities, renal agenesis, this is a failure of the ureteric buds to form, leading to no kidney formation. And remember Potter's syndrome. Bilateral renal agenesis leads to oligohydramnios, which leads to fetal compression resulting in limb deformities such as clubbed feet, facial deformities, and pulmonary hypoplasia. Another thing that can happen is horseshoe kidney, which is a fusion of the inferior poles of the kidneys. Ascension of the kidney is prevented by the inferior mesenteric artery and remain low in the abdomen. It may cause other renal vascular anomalies. and it has normal kidney function if you have a horseshoe kidney. Things to remember there. So before we listen to some questions from the Q Bank, let's listen to some tune. What should we listen to? How about Al Jarreau, Morning? Okay, so that was Al Jarreau, Morning. That's a great song. Okay, let's look at the MCQs now. What I'm going to be doing is we're just going to be reading the questions from the MedBullets website, and I'm just going to look at the answer. I'm not going to read all of the research studies that come with it, so we're just going to read the basic answer. So here we go. Number 1. A 28-year-old pregnant female presents for a prenatal checkup at 20 weeks gestation, which includes routine screening ultrasound. Fetal ultrasound demonstrates bilateral multicystic dysplastic kidneys. Her pregnancy has been complicated by persistent oligohydramnios. The child requires significant pulmonary support upon delivery. Which of the following clinical findings is most likely present in this child as a result of these abnormalities? 1. Urachal fistula. 2. Esophageal atresia. 3. Spina bifida occulta. 4. Clubbed feet. Or 5. Macrosomia. And the answer is 4. Clubbed feet. Discussion. Bilateral multicystic dysplastic kidneys are seen in Potter syndrome, in which club feet is also common, which also manifests as a sequence of deformities of the limbs, club feet, face, suborbital creases, depressed nasal tip, low set ears, retrognathia, and lungs, pulmonary hypoplasia. And the basic discussion here they give. Bilateral renal agenesis is the most common cause of oligohydramnios, which is a deficiency of amniotic fluid, and can result from conditions such as bilateral multicystic dysplastic kidney, or a genetic disorder leading to malformation of the ureteric bud. Many different structures are involved in Potter syndrome, including the limbs, club feet, face, suborbital creases, depressed nasal tip, low set ears, retrognathia, and lungs, pulmonary hypoplasia. Potter syndrome can be fatal shortly after birth due to pulmonary hypoplasia and subsequent respiratory failure. So let's think about that for a second.
a nice day for a white wedding. It's a nice day to start again. Hey little sister, what have you done? Hey little sister, who's the only one? I've been away for so long. I've been away for so long. I let you go for so long.
Okay, sorry to interrupt you, Billy Idol, but we're going to go to the next question. Okay, question number 2. At a 20-week screening ultrasound of a 31-year-old G1PO woman, P0 woman, the technician finds bilateral renal aplasia. While discussing the findings with the expectant parents, the physician notes that this condition leads to which of the following? 1. Polyhydramnios. 2. Intraventricular hemorrhage. 3. Pulmonary hypoplasia. 4. Ventricular septal defect. Or 5. Malrotation of the midgut. And the answer is 3. Pulmonary hypoplasia. This fetus with bilateral renal aplasia will have oligohydramnios, which leads to pulmonary hypoplasia. Classic Potter syndrome, also referred to as Potter sequence, is a disorder of neonatal development that begins with bilateral renal aplasia, which leads to oligohydramnios. Although amniotic fluid initially originates from maternal plasma, as pregnancy progresses, fetal urine output contributes to fluid volume. The fetus swallows the fluid, which contributes to lung development. As a result, without developing kidneys, insufficient amniotic fluid leads to pulmonary hypoplasia, as well as clubbed feet and facial abnormalities, both from intrauterine compression. Clinicians now often use the term to refer to infants with this constellation of findings, regardless of the origin of oligohydramnios. The classic syndrome is both rare and fatal due to respiratory failure. So there we have that. So let's think about that for a while.
Don't go changing to try and please me. You never let me down before. Don't imagine you're too familiar, and I don't see you anymore. I would not leave you in times of trouble. We never could have come this far. I took the good times, I'll take the bad times. I take you just the way you are. Don't go trying some new fashion. Don't change the color of your hair. You always have my unspoken passion. Although I might not seem to care, I don't want clever conversation. Never want to work that hard. I just want someone that I can talk to. I want you just the way you are.
Okay, that's Billy Joel. Okay, let's move on to the next question. A 27-year-old female in her 20th week of pregnancy presents for a routine fetal ultrasound screening. An abnormality of the right fetal kidney is detected. It is determined that the right uretopelvic junction has failed to recanalize. Which of the following findings is most likely to be seen on fetal ultrasound? 1. Bilateral renal agenesis. 2. Unilateral hydronephrosis. 3. Renal cysts. 4. Pelvic kidney. 5. Duplicated ureter. And the answer is number 2, unilateral hydronephrosis. Failure of the uretopelvic junction to recanalize will result in hydronephrosis, which is unilateral in this patient, based on the ultrasound. Kidney development proceeds through 3 primary phases: pronephros, mesonephros, and metanephros. The metanephros, as the permanent kidney, first appears during the 5th week of gestation. The ureteric bud interacts with the surrounding metanephric mesenchyme. The ureteric bud ultimately forms the ureter, pelvis, renal calyces, and collecting ducts. The metanephric mesenchyme develops into the renal parenchyma, including the glomeruli and renal tubules, to the distal convoluted tubule. The ureteric bud initially appears as a solid structure, but is recanalized in a distal to proximal direction. Therefore, the uretopelvic junction is the last portion of the developing ureter to recanalize and is the most common site of ureteral obstruction. Typically, in normal development, urine production by the metanephros begins during the 8th to 10th weeks of gestation, and the ureters are completely recanalized by the 10th week of gestation. So there we have it. And, the reason I read these out is because I'm able to remember these, and I think this is a really great way to study for exams, whether you're studying for the USMLE or your basic medical school exams. It's great to go through review sites such as this. Another one is great is osmosis.com, and there are a lot of other videos on my website. A lot of other podcasts about pathologystudent.com. Great things on there. I really recommend you go there and have a look. And today we're looking at medbullets.com. So let's take another little break, and then we'll come back.
Turn your magic on, to me he'd say everything you want and dream away. Oh, we are legends every day. That's what he told me. Turn your magic on, to me he'd say everything you want and dream away. Under this pressure, under this weight, we are diamonds. I feel my heart
Okay, let's look at question number 4 here. A child is born by routine delivery and quickly develops respiratory distress. He is noted to have epicanthal folds, low-set ears that are pressed against his head, widely set eyes, a broad flat nose, club feet, and a receding chin. The mother had one prenatal visit, at which time the routine ultrasound revealed an amniotic fluid index of 3 centimeters. What is the most likely underlying cause of this patient's condition? 1. An extra 18th chromosome. 2. Bilateral renal agenesis. 3. Autosomal recessive polycystic kidney disease. 4. Unilateral renal agenesis. 5. Microdeletion in chromosome 22. So I'd be confused if I saw bilateral renal agenesis and unilateral renal agenesis. So you really have to know what would happen if you had both kidneys absent. So the answer here is bilateral renal agenesis. The child has Potter syndrome, which is defined by the characteristic dysmorphic appearance of a neonate secondary to oligohydramnios during fetal development. The most common cause of Potter syndrome is bilateral renal agenesis. Any cause of oligohydramnios can lead to Potter syndrome. The amniotic fluid index, AFI, is an estimate of the amount of amniotic fluid as measured with ultrasound. A normal AFI is between 8 to 18, and anything less than 5 to 6 is consistent with oligohydramnios. While bilateral renal agenesis is the most common cause, it can also be caused by renal hypoplasia, urinary tract obstruction, and polycystic kidney disease. Amniotic fluid acts as a cushion for the growing fetus within the uterus. Oligohydramnios reduces the cushioning effect and leads to facial compression, resulting in these characteristic dysmorphic features, i.e. epicanthic. Epicanthal folds, low-set ears that are pressed against the head, widely set eyes, a broad flat nose, club feet, and a receding chin. Potter syndrome is also classically associated with pulmonary hypoplasia and club feet. Bilateral renal agenesis is rare, occurring in 0.1 of 1,000 births, and prognosis is dismal, as bilateral renal agenesis is incompatible with life. So there we have it. That was number 4 of this discussion about kidney embryology, a question I'm expecting on my final, one of the many subjects. So I just thought I would go through this. So again, today we were looking at med bullets. Expect to see more of these summaries. I find them very helpful for me. So let's finish up with a song. What should we listen to? Or listen to the Commodore Sail On, but let's listen to something else.
Cause how you gonna
even trying your shoes.
Thanks very much.